In this next talk, I'm going to talk about how you can then take the evidence that you've found through your literature searches and formulate recommendations and present those in a coherent set of guidelines. So we're going to talk a little bit about how we might summarize the evidence, what the structure of a set of guidelines might look like. I'm going to talk more specifically about how to word recommendations to make them as clear as possible and easy to follow, and then a little bit about making research recommendations. So once we've finished our literature searches, we've hopefully identified all of the evidence to answer each of the questions that we want to address in our set of clinical practice guidelines. And we now need to summarize that evidence and provide some clear, straightforward recommendations for practice where possible, where the evidence is strong enough. We want to try and keep it as succinct as possible. We want to use all of the available evidence in order to answer the questions. One of the risks at this stage of developing guidelines, if you don't follow the process correctly, is that you can introduce your own biases by selecting out the evidence that supports the arguments that you want to make in your set of guidelines, rather than considering the body of evidence as a whole and being balanced and fair about it. If you follow the methodology carefully and you make sure that you identify all of the relevant literature and consider the whole of the body of evidence to answer each of your key clinical questions, then you can avoid the introduction of your own biases when you're writing up your guidelines and formulating your recommendations. So the first question to ask is, well, what does the evidence show? Okay, what's the effect that we're seeing? And how big is that effect? Okay, is that effect statistically significant? And is that effect clinically significant? And they're not necessarily the same thing. You can have a highly statistically significant result because you've got lots and lots of patients, but actually the magnitude of the effect you're seeing on the outcome that you're interested in can actually be, in real clinical terms, quite small and probably not of any clinical relevance. So for example, if you combine in a systematic review 30 studies to show a difference in GFR of 2 or 3 milliliters per minute, you might achieve statistical significance. You might get a p-value of 0.001. But that difference in real clinical terms is probably not that important. You know, a 1-year difference in GFR of 2 mils per minute is probably not going to be that relevant. On the other hand, if you haven't got enough patients and you're very imprecise in your results because of a lack of power, you might have a finding that could be clinically significant, but you're lacking enough evidence to show statistical significance. And the way to look at this is to look at the width of the confidence intervals in your effect estimate and say, well, okay, you know, the lower or the upper bound of that 95% confidence interval could both be clinically important. So we simply just don't have enough data here to be able to tell us whether there is a real effect or not. And there could still be a clinically significant effect, despite the fact that we haven't achieved statistical significance. The next thing you're going to want to think about is that balance between benefit and harm. So benefit is obviously treatment effect or efficacy, potentially in terms of costs or in terms of patient-reported outcomes. But of course, that's got to be balanced against any risks of your intervention. So if you're talking about a treatment, it might have side effects. It might have a negative cost impact. It might require increased testing, increased hospital attendances, or discomfort for patients that make it unacceptable to patients. Sometimes we might not have all the information that we would like to be able to see to be able to make this judgment. So a lot of studies will report efficacy data and possibly a bit of side effect data, but they might not report any patient-reported outcomes. So whilst we know whether a treatment works or not, we might not know whether it's acceptable to our patients or whether our patients are going to be able to, you know, tolerate it. The next thing to consider is the evidence consistent? Okay, and by this we use the term heterogeneity, which is that difference between different studies in terms of the effects that you're seeing from a treatment. And heterogeneity can occur in two ways. It can occur in a size of the effect. In other words, the effects are all in the same direction. They might show a benefit of treatment, but we're just not certain how big that benefit is. And in some ways, this is a little easier because we can say, well, okay, we know that there might be a benefit or there might be a harm to our treatment. The fact that we don't know how big it is, it doesn't really matter as long as the effect overall we think is going to be clinically significant. Where it gets more difficult is where you've got a lot of studies that have different directions of effects. And now we don't even know whether there is an effect or not. And in that situation, you've got to think, well, why are the results of all these studies different? And why are we seeing so much variability in the outcomes that we're interested in? And that can be because of the methodology of the studies, or the quality of the studies can vary, so have led to spurious results, or sometimes can be differences in the way the studies were conducted, or the patients or the interventions used in the studies. And when you're thinking about this, you need to look into those studies and say, well, okay, which of these studies have got patient populations or in healthcare settings similar to ours, so that we can judge whether we think that this treatment is going to show a benefit or not in our particular population. Sometimes you may not be able to draw that conclusion from the data that you have. Sometimes it will be evident what the differences between the studies are. As you saw in an earlier talk, if the underlying evidence has a high risk of bias because the study methodology was poor or the reporting was poor, then of course you're going to be far less certain of any conclusions that you can draw when you compile all the evidence together to try to make recommendation. It's the old adage of rubbish in, rubbish out. So if you find a high risk of bias in your underlying studies, or the methodological quality is poor, then clearly you're going to grade the recommendations that you make accordingly. The final thing to consider is the evidence generalizable? So are the studies that we're looking at from the literature that we're making our recommendations based on in populations and using interventions in a similar way that we would consider using them in our practice? So if we're developing guidelines for the UK and we've got a whole bunch of studies in a US healthcare system that works in a very different way, we have to consider whether those studies and the results of those studies are likely to be the same if we were to use that intervention in our population, in our healthcare setting. Okay, and part of that is to do with cost and resources and whether these things are feasible within the infrastructure we have. And part of that might be to do with acceptability, both to clinicians and to patients, which is why it's so important to have patients involved in your guideline development process. So there are lots of different ways of formulating your recommendations once you've compiled all the evidence together. Usually it's some form of consensus agreement, often using something like Delphi models for voting on recommendations to go into the guidelines. Sometimes it's a more informal approach. It doesn't really matter how you do it, as long as all of the necessary stakeholders are involved in that decision-making process and all of the evidence is considered in a fair and unbiased way whilst you're making those agreements. In some cases, it might be useful to split your guideline development group up into smaller subgroups with particular expertise in a particular area to formulate recommendations for that particular section, and then report back to the development group as a whole as part of the consensus process for voting on whether those recommendations should make it into the final guideline. Once the guideline development group are happy with the set of guidelines as they've been developed, as they've been written, then usually you should put that out to consultation. And that public consultation could involve all the necessary stakeholders, the end users of your guidelines and the various different groups that might be involved, as well as patients and carers and other groups that might have a vested interest. We talked a little bit earlier in one of these other lectures about stakeholders, and people like commissioners, payers, hospital admin may want to be involved in this process because they're the ones that have to implement these guidelines and ensure that we're trying to adhere to them if they're considered to be best practice. It can be very useful to use local and national societies to disseminate these out for consultation. And once you've been out to consultation, it's really important that any questions or comments that you get back are transparently dealt with and addressed in the final version of the guidelines, and responses are made by the guideline development group to each of those points made by the people being consulted. So this is the sort of overview structure of what a set of guidelines will look like. We've talked about most of these areas already, so the aims, the objectives, the stakeholders, a clear description of the methodology you've used, the search strategies, how the evidence has been selected, how the risk of bias has been assessed and the evidence has been graded. We'll then summarize that evidence in a narrative form and then provide some key recommendations along with grading and link to the evidence. And I'll talk a little bit more detail about how we might phrase those recommendations in a minute. Details of the external review process and any responses to any comments that came back from the external review, procedures for updating, and then advice on implementation and how the adherence to the guidelines can be audited to ensure best practice is being followed. It's really important to remember that when you're framing your recommendations, and these are the key recommendations in your documents, these are usually pulled out in a box, bullet pointed, in bold text within your guidelines so they're easy to identify. These are probably the only bit that most people will read of your guidelines. They won't read the detail of the underlying evidence. They probably won't look at your methodology. And so it's really important that these are fair, unbiased, clear, easy to read, easy to identify, and that the grade of the evidence is clearly stated so that you know the certainty to which these recommendations are being made. So each recommendation within your pulled out boxes should include a clear statement of the recommended action, an intent of the recommendation action, so what it is you're trying to achieve, the relevant population, any caveats or exclusions to whom the recommendation may not apply that you've identified from the literature, and the degree of certainty or uncertainty, in other words, a grading of your recommendations. It is worth considering looking at the NICE guideline development handbook. There's a very nice chapter in there on how to formulate recommendations and the best way to phrase recommendations. And my following slides are going to look at some of those recommendations made in that process. So NICE recommend that you focus on the action and that your recommendations should start with a verb. And this makes for really clear, unambiguous recommendations. So if you start with a word like offer, measure, test, advise, discuss, ask, you end up with a very clear recommendation. So a direct instruction such as test all donors for hepatitis C virus, ask all potential recipients about symptoms of peripheral vascular disease, perform surgery within 48 hours. It's important to remember that because most people coming to your guidelines are only going to look at these recommendations, that they have to stand alone. So a bit like a table or a figure in a published paper, you want the legend or you want these recommendations to stand alone and be understandable without having to delve in and read the rest of the document. So avoid using technical terms, abbreviations that require further definition in the paper, and make sure that everything is clearly identified. If it's not really clear from the scope of your guidelines, make sure that you define the target population for each recommendation and just limit yourself to one action per bullet point or one action per recommendation and separate them out clearly. Emphasize patient involvement in decisions. So try not to use words like prescribe or give because they imply that we're deciding what we do for the patients and the patients don't have any say in it. Use offer, consider, discuss, because that implies patient involvement in their own care. You know, we're not being prescriptive, but this is what we would recommend. Use people rather than paper, particularly these impersonal words like cases or subjects. And really most recommendations fall into one of three categories in terms of the strength of recommendation. There are those that are must or must not be used. There are those that are should or should not be used, so relatively strong recommendations, or those that could be used where the level of evidence is perhaps less certain. Must recommendations generally are reserved for situations where there is a legal or regulatory duty to comply with a recommendation, or if the seriousness of not complying with a recommendation is so strong that you really feel that the word must applies. So for example, if there's a very high risk of death without a particular action being taken, then you might consider using a must recommendation. And in that case, you can make an explicit statement using the word must. Most recommendations are going to be relatively strong recommendations, but don't quite fit into that category of that degree of harm if they're not followed. And in this case, we would define these as being should recommendations. So we recommend you should or should not use a particular intervention, a particular test. And here is where we would use those direct instructions that we talked about. So we don't use the word should, we just say, ask all potential recipients about symptoms of peripheral vascular disease, implying that it should happen in most cases, in most situations. If you've got 2 or more options, offer a choice. When we're less clear about the quality of the evidence or the strength of the underlying evidence, we will provide an option. In other words, use the word could. Okay, and here we tend to use consider to indicate a less strong recommendation. So consider a DMSA scan. We got more than one option. You say consider drug A or drug B. Try to avoid confusing terms which could imply should or could recommendations. So try to use things like consider offering, where you've got consider and then another verb afterwards. Above all, use plain English. Make these recommendations as clear and as understandable as possible. When you're talking about drugs, use generic drug names. Avoid the use of doses. They can be looked up elsewhere and they may lead to confusion. And highlight recommendations for off-label use. If you're recommending a drug for off-label use, make sure you identify that within your guidelines. So these are some examples of good practice. So offer APOL1 genotyping to all people of African heritage being evaluated as potential kidney donors, or consider regular antibody screening in living donor kidney transplant recipients undergoing reduction or withdrawal of immunosuppression. So nice, clear, unambiguous recommendations that reflect the strength of the underlying evidence. And of course, each of these statements would be followed by a grading of the underlying evidence. Of course, often we don't find enough evidence to be able to make clear recommendations, and we're left with more questions than we have answered. And this is true of guidelines exactly the same way as it is when you're undertaking a systematic review. So any review of the evidence is likely to identify some areas where you just don't have the evidence, and you want to make some research recommendation to say, well, okay, we've identified a gap in the evidence. How could we address that? And one of the useful things to put in guidelines, perhaps towards the end of your set of guidelines, is future research recommendations. So what don't we know that we would like to, and we really do need to know, and how we address that gap in the evidence? So what studies need to be done in order to help us to answer that question? So in summary, we're going to consider all of the available evidence. We're going to consider the strength of the evidence, the statistical and clinical significance. We're going to consider the balance between benefit and harm. We're going to consider the consistency of the evidence and the heterogeneity. And we're going to consider the quality and the risk of bias. And we're going to try and formulate clear, direct recommendations in plain English that are really easy and unambiguous to follow.